Good to see young men presenting in conferences. This young man, he used to be a rapporteur in KOGS, KMA, so he has a good future.
Okay. Just a second as it comes up. So good afternoon, everyone. My name is Dr. Kelvin Thiga from Consolata Mathari. I work with Dr. Musa Frentino. So I'm going to present, I'm a medical officer intern. I'm going to present a case report on when delivery becomes the cure, reversible paraparesis in late pregnancy. So I did this guided by my consultant in obstetrics, Dr. Musa Frentino, and also my consultant internal medicine, Dr. Musana Emmanuel. So this will be the outline of my presentation. So to dive deep into it, so there's no conflict of interest to declare, and before presentation of this case study, informed consent was sought from the patient. So background, neurological deficits are rare, pretty rare in pregnancy, and paraparesis tends to be described as complete or partial loss of voluntary motor function of the lower limbs. You can have multiple etiologies I will come to see as we go on in the discussion. Therefore, one key cornerstone of diagnosis is proper history and physical examination, and especially being the gynecologist, or especially in running or anywhere you are the primary caregiver or the first point of contact with the patient, you have to rule out particular red flags that I will get to mention. Also, we cannot rule out the importance of magnetic MRIs and also nerve conduction studies, which are really good or important in ruling out some of the differential diagnoses. And we'll also discuss the role of multidisciplinary team in management. Now, what makes the management of such neurological deficits a bit complex is some of the things that you have to consider, which includes the diagnosis, the severity of the symptoms, and importantly, the gestation at which the mother presents at. So our case, the objective basically is to highlight this representation of reversible lower limb weakness presenting in pregnancy, and especially in our context, it is in the late trimester. Yeah. So if it comes a bit early, so this particular it's in the third trimester. The next thing is to basically show you how delivery was a potential therapeutic intervention. And basically, I've not seen this discussion anywhere. For the past 2 years that I've rapporteured in KOGS, the bigger conference, I've not seen a conversation around neurological deficits in pregnancy. So maybe these can spark conversations around Kenyan protocols on management of spine conditions in pregnancy. So my case is a case of a 22-year-old primigravida. Gestation by dates was 37 weeks 1 day, and by ultrasound 1, as you can see, is 38 weeks 1 day. So she had presented with a day history of lower limb weakness, which was gradual in onset. The reason why I'm highlighting it is because you can have one of the differential is sudden onset, but this one was gradual onset lower limb weakness. It was also associated with right knee pain and numbness with tingling sensations when lying on the right side. There were no sensory losses or bowel or urinary incontinence. You see, that's another red flag that should be able to rule out. There was no report of trauma, yet another differentials or any recent infection. From a physical examination, she was vitally stable, but there was notable bilateral lower limb edema. Neurological findings, and these were, I would like us to pay our attention, because this is one of the simple ways that you are going to use to follow up our patient, is she had a reduced power on the right lower limb was 3/5, on the left lower limb was 4/5. The reflexes were intact. That also gives another clue to a differential. And sensations were intact, another clue. The anal tone was intact, another clue. But the gait could not be assessed simply because the patient could not stand on her own, so there was that fall risk. But so she could not walk and needed assistance. So our initial investigations, the lab works, fairly normal, just had a normal cytic anemia and just an elevated ESR. Investigations, one, an obstetric scan. Basically, at this time, that trimester, fetal-maternal monitoring becomes an important component of it. So obstetric scan was good, showed a single intrauterine fetus in cephalic presentation. Just wanted to rule out that she did not have DVT. Significantly, this patient had initially been treated for DVT in the left upper limb and was already on rivaroxaban. Two things were not available, but were recommended to be necessary: nerve conduction study and lumbosacral MRI. Maybe to just mention, in our center, for you to get for pre-authorization of an MRI to be worked through for SHA, one has to have a lumbar x-ray. So I don't know how do we go about when you have an expectant mother. So clinical reasoning. So this young lady, 22-year-old female, presenting with a day history of lower limb weakness. What are the possible differential diagnoses? We call the physician on board, and we try thinking through about it. So I said history and physical exam become important cornerstones in diagnosis, because one of the things that popped us was GBS. If you go through literature, we'll see that lower limb weakness and inability to walk and paraparesis has been discussed extensively in the context of GBS. But you can see we did not have any presentation of any ascending paralysis. So yes, GBS is likely, but it's not there. Multiple sclerosis, we talked about, you have to have an asymmetrical presentation, and non-traumatic spinal cord compression, and the most dreaded thing when it comes to spinal cord compression is Cauda-Equina syndrome, where you're tipping over to irreversible spinal cord damage. So therefore, it becomes important for you to rule out your red flag sign and symptoms. So don't, even if you're the obstetrician, maybe this is where a DRE is indicated for you as well. So functional neurological disorder is another, came up as another differential diagnosis, but here you have to have other neuropsychiatric, neurocognitive manifestations, psychiatric manifestations. So you have to have really a good history. So by the end of it all, we postulated that this might be a pregnancy-related mechanical compression, but you can all appreciate that in the absence of an MRI and in the absence of a nerve conduction study, in a way, we had a diagnostic uncertainty. But it gets a bit interesting. So it's a multidisciplinary approach in management. The obstetrician and the physician are on board, and then family-centered care. Because when we engaged the family, they were really adamant. They really wanted us to prioritize delivery, delivering the baby, because the mother, you remember I gave you the gestation ages, and then you'll even get, in the next slide, you'll get to appreciate at what time are all these things happening. So the family was a bit adamant. We want a family, we want to prioritize delivery. Yeah. So just continuously fetal-maternal monitoring. So as the clinical team, we decided to focus on conservative management, physiotherapy, and pain control. So we really got some mild improvement. So along the way, now delivery becomes important conversation to have, because now what more do you want to achieve? When you look through literature, lower limb weakness or paraparesis or even inability to walk has been linked to delivery, SVD, normal delivery, and then a woman gets lower limb weakness. So ours here is already presenting with paraparesis even before delivery. Therefore, there was no strong obstetric indication, but we resulted for an elective CS, that was day 8 post-symptom onset. So the outcome was a live male infant, APGAR 8, 9, 10, and the birth weight was that 175. This one, now post-op, how was the patient? 6 hours post-op. Now, ideally in our center, we remove the catheter and we expect you to ambulate, to start moving around. The power in the lower limb had markedly improved. The mother could stand with assistance, right? But within 12 hours post-operation, she could fully ambulate, take herself to the washroom with no residual neurological deficits. It was like a miracle. We were even wondering. So this is basically a timeline. On 8th of April, the patient has this onset of symptoms. That is day 0. On 10th, we admit in our facility. On the 13th, we start having, we have the physician already on board, and we are proposing all these things to do. But now also the pressure from the family to deliver comes, and we deliver on day 17. Day 17, that is on a Friday. Going into Saturday, we already have a good outcome. Even now, we are already discussing. Now, ideally, day 3, once you expose the wound, you are supposed to be discharged. So ideally, she should have gone home on Sunday, that is 19th. But you don't discharge people on Sunday. She went home on Monday. Now, post-discharge follow-up, the lady is ambulating, running, no pain. Actually, she's saying, mimi niko sawa. So, discussion. This case, when I was just having a conversation with my consultant, Dr. Musa, He told me that he has experienced almost similar presentations in a particular mother who at every time that she gets expectant and she gets to a particular gestational age, she gets this such a presentation. So what we are postulating is this is a form of a form of a neuropathy, which could be a mono or a polyneuropathy, whereby you have the gravid uterus compressing on the plexus, the lumbosacral plexus, and hence the presentation. There's one of the references, as indicated below, they were discussing about the role of relaxin. Relaxin, as it causes muscle laxity in the different tendons and different ligaments. You have an exaggerated lumbar lordosis. Remember that your nerve roots are exiting on the back. So if you have an exaggerated lumbar lordosis, you also have that compression of the nerves. Now the other thing is you have to really rule out your red flag signs, which include altered sensations, which sensations were intact in our case, reflexes were intact, pain in the legs, bowel and bladder dysfunction, saddle anesthesia, and sciatica. Therefore, we concluded that mechanical compression by the gravid uterus was a plausible explanation to the presentation, because post-delivery and alleviation of whatever was compressing the nerves, we got a complete resolution of the symptoms. So when you looked at the literature, if I asked how many have seen maybe a similar story, maybe most of us can raise their hands. But when you go to published work or any case reports, you're not getting anything. What you're getting, the closest you can get is GBS or other pulses like the foot drop. Therefore, we need to generate a bit more evidence so that we can be able to even be guided. So how do we do proper patient selection? If I'm working in a resource-limited setup, when do I know that this one I just need to watch and see, but this one I need to really refer? So there were some few limitations. One, that is lack of a definitive diagnosis due to the absence of the MRI, as I've said, and the nerve conduction study. And this is a single case. If we had more pooled cases, we can be able to correlate more. And the lack of standardized definitions adaptable in obstetrics. But I think the question that I'm constantly asking myself, how do I know that recovery wasn't coincidental? Perhaps we need more data to be generated around the area. So in conclusion, neurological deficits indeed are rare in pregnancy. Based on the particular time of presentation, different things have to be considered. You have to rule out your neurological red flags through your history and physical examination, and we cannot disregard nerve conduction studies and MRI, they are all in it. Management is multidisciplinary. Sometimes you'll even have to involve the neurosurgeon where you want to do decompression in case of severe spinal stenosis. And then planned delivery, patients, we have talked about the planned delivery, the mode and timing, patient selection, yeah? And then delivery is a cure for reversible paraparesis in select patients. Asante sana, those were my references, and this is my acknowledgement. Asante.